Hello again, and welcome back to Oncology Brothers podcast. I'm Rohit Gosain, and here, as always, with my brother and co-host Rahul Gosain. Today, we are going to dive into the world of neuroendocrine tumors. To cover the current landscape and recent advances in this disease, we are joined by world-renowned medical oncologist in this field, Dr. Pamela Kunz from Yale Cancer Center. Pamela, thanks so much for joining us.
Thank you for having me.
Pamela, welcome. Congratulations on your recent promotion as a professor now.
Thanks.
All right, getting back to the neuroendocrine story, can we start off by laying the foundation on different grades, histological features, Ki-67 that we have to keep in mind when we talk about neuroendocrine tumor? And what is that workup in your clinic? Do you get gallium PET-CT for all your patients? Can we start here and keep that patient in mind in front of us in the clinic?
Sure. No, thanks so much. And this is complicated, even for those of us who do it frequently. And I really try to involve my patients in describing shared terminology. I think that's actually something I do from the get-go. So as we think about evaluating a patient, I first talk about primary site, so NETs being categorized in multiple different ways. So where do they start? Pancreas, small intestine, lung, other, unknown primary. Then we think about grade and differentiation. So is it, and those are really with the help of our pathology team, and we rely very heavily on them. The WHO classification criteria have really changed considerably over the last 10 to 15 years, which is why we're all so confused because the terminology keeps shifting. At present, we're using well-differentiated grade 1, 2, and 3, neuroendocrine tumor. So if it says tumor on a pathology report, it generally implies that it's going to be well-differentiated. And then we're calling it poorly differentiated neuroendocrine carcinoma. The Ki-67 plays in because that determines the grade 1, 2, and 3. So grade 1 is going to be Ki-67 1 to 2, grade 2 is 3 to 20, and grade 3 is greater than 20. And in general, this is not part of the WHO criteria, but the poorly differentiated neuroendocrine carcinomas in general are going to be greater than Ki-67 of about 55%. There's some exceptions to that, but you're generally going to see that Ki-67 be quite a bit higher. And then we talked about well-differentiated and poorly differentiated, and the pathologists help us look at that. And then we think about stage, and you guys nicely here on your slide are thinking about localized and metastatic disease, and that's absolutely critical as we think about tailoring a treatment to the patient. So, and I definitely use a gallium-68 PET-CT. Some institutions will use copper-64. They're really interchangeable, but a somatostatin receptor imaging, a PET or SSRI imaging is something that we will use. Octreotide scans have really fallen out of favor, given that our PETs have much better resolution. The way I describe that, why that matters for patients, is that it really helps us determine extent of disease. It complements our cross-sectional imaging. It doesn't replace it. So our primary tool for evaluating patients with NETs will still forever be either a multiphasic CT or an MRI. The PETs will do at time of diagnosis and intermittently to answer specific questions.
Perfect. Well, thanks so much for summarizing and laying that foundation, Pamela. Now, when it comes to this particular disease, we have to make a treatment decisions, and not every localized treatment or metastatic patient has to be treated with something. We can, in fact, observe these patients. So the treatment decision really depends on the extent of the disease, symptoms or versus no symptoms, which is functional versus non-functional, diarrhea, flushing, or carcinoid type symptoms, the grade status. In terms of how you decide your treatment, what is your discussion with the patients? When do you consider treatment modality itself?
Yeah, it may be. I totally agree. All of those factors come into play. So for a patient with localized disease, that is a patient that assuming that they don't have medical comorbidities that preclude a surgery, we generally will recommend surgery. And then most of those patients don't need subsequent treatment. So I think that's true for the well-differentiated grade 1, 2, and 3s. We're a little bit more cautious with the high grade, with the poorly differentiated neuroendocrine carcinomas and thinking about surgery even for localized disease, but that's a very nuanced conversation. So we'll set that aside for now. For patients with metastatic disease, this is where it gets complicated. I would say for patients who have grade 1 or 2 well-diff neuroendocrine tumors who are asymptomatic and non-functional, we might consider observation. Those are the patients that get incidentally diagnosed. Maybe they go into the emergency room for some unrelated issue. They're found to have perhaps low volume disease, get the diagnosis. I will comment that the kind of functional neuroendocrine tumors really are defined as patients who have a measurable hormone in the urine or the blood and symptoms of hormone excess. That's a reason for symptoms, but some of our patients with NETs will have symptoms from tumor bulk. So if they have large liver lesions. So either of those two sets of symptoms may push me into thinking this patient needs treatment sooner. So if it's a patient with symptoms from tumor bulk, we really need to think about what treatment options do we have that will yield tumor shrinkage. There honestly aren't that many in NETs. For pancreatic NETs, we have capecitabine temozolomide, we have Lutathera. Both actually have a chance of tumor shrinkage. For small bowel NETs, our options are even further limited, but we have Lutathera that has about a 1 in 5 chance or 20% shrinkage rate. Our somatostatin analogs, biologic therapies generally yield stability and don't usually yield tumor shrinkage. So it's sort of what you think about, what agents do you have available? What outcomes do those treatment options yield? So is it shrinkage or stability? And that helps me think about how to tailor those treatments.